Welcome everyone. My name's Sue O'Sullivan. I'm the Assistant Director for Health Service Planning in the Department of Health the department, and I welcome you to this session, this information session this morning. The purpose of this is to build on our previous information session that we held at the end of July. And we have accepted questions from the sector, and we hope that we are going to be able to answer some of those questions and provide you with more information on issues that you may be experiencing as part of the implementation process. So I have introduced myself. I will pass over now to my colleague.
Hi, so I'm Roxanne. I've met many of you before from the Victorian Tasmanian PHN Alliance, so I'm coordinating the PHN effort for the Specialist Clinic Reform.
And I'm Karen O'Leary. I also work in Sue's team with ambulatory policy.
Thank you. So back over to me, and I'll start with what we will be talking about today, our agenda. And as you can see on the screen, we're hoping to cover off our objectives. What are the initiatives in specialist clinics that we are undertaking at the moment which support the implementation of statewide referral criteria? Our key timelines for implementation, our current communication with health services and with PHNs, the resources that we've developed, also our current panel work and feedback on the criteria that we have on the website to date. We will be looking at PHN engagement strategy with GPs, and also at the end we will be talking about the questions that we've received from the sector, and we will provide answers to those. So first up, I want to talk about, what are statewide referral criteria? That they're standardised tools to assist GPs and other referring clinicians to know when a referral to a public specialist clinic is appropriate and what information should be included in the referral. The objective of the work that we're undertaking at the moment is to ensure that patient referrals are assessed the same across all in public health services. We're also looking to ensure that referral and communication processes between referrers and specialist clinics are improved, and also that referring clinicians know when a referral to a specialist clinic is required and the information that should be included in that referral. So what we know, this is a slide that we presented in our information session in July, but I think it's good to have a look at it again and understand that this isn't going to be an easy process. It's taken us years to get here. As a large system transformation, it will need a long-term focus and multiple approaches that will provide incremental change. We need to focus on equity of access and appropriateness, not just access. There must be an alignment between general practice and public health services in order for this to be successful, and consistent statewide referral criteria takes us closer to that. Just a recap of some of the other specialist clinic initiatives that are ongoing at the moment. Most of you will know that we are refreshing the access policy for specialist clinics, and its key role will be to better articulate the role and purpose of specialist clinics. There have been some delays in sending that out to the sector following an Auditor General report and recommendations. We are hopeful that that will be sent out by the end of the year for implementation by health services. We also have a waitlist audit work being undertaken. Funding has been provided to health services to undertake specialist clinic targeted waitlist validation, and I know that our templates following that work are now being sent in, and it will be interesting to see what what has happened out in the sector and what impact that's had on the waiting list. We're also developing new specialist clinic KPIs in 1920 as shadow indicators, and the focus will be on clearance times. Further information will be provided to health services via CEOs once that becomes a little clearer, but certainly those are being developed now. There's funding model reform being undertaken by our funding policy team, and the aim there is to move it gradually from a shadow model to actual implementation to activity-based funding. And the aim is to improve flow incentives to ensure that health services and their processes are improved to ensure those most in need are funded appropriately. Telehealth is another area of targeted investment which the department has provided to the sector, and the big focus there is improving access to specialist care for rural and regional patients. And finally is e-referral. A consortium of health services have been funded to develop and implement e-referral capability. And one of the items that hasn't been included in here is also our annual change processes for data, for VINA data. That will be going out to the sector shortly, and we'll be very interested to hear from our specialist clinics as to their data items that have been included and their value in including them into our manual. Key dates for implementation. I've sent out an email to everyone providing these and just wanting to make sure there's consistency of approach. All Victorian health services are required to use the published statewide referral criteria to assess all new referrals as follows. You'll see them on the screen there. The 1st of November will be ENT, vascular and urology. The 1st of February of next year is neurology, gynae and gastro. There are a number of other specialties that are being developed at the moment and panels being undertaken, and Karen will refer to that in her presentation. Again, reiterating that where there's no published statewide referral criteria for a presenting problem, health services should continue to use their own local health service criteria. And as noted, there will be an ongoing rollout of criteria for additional specialties over the next 2 years. Recently, I've sent out resources to health services to support implementation, and I've put out a readiness checklist which will support service improvement, development and planning. I've had some positive feedback regarding the checklist, and the aim is to assist to identify priority elements for action and a process to implement the criteria. I've also sent out frequently asked questions. They are a list of the questions and answers that probably we've received from the sector, giving, I suppose, basic information to health services about implementation. I'm sure that following this session, we will receive further questions and the Q&A will be updated. And finally, the fact sheet that was sent out as well, and that emphasises key points about the criteria and implementation. Our communication and engagement to the sector has really been via email to date, and I've been sending them to executives of specialist clinics, our funded project officers, CEOs of rural health services and also our GPLO network, and to our PHNs. If you would like to be included in those emails, please send those details to the email address noted in the slide and we will add you to the list. Just wanted to confirm that we've also been consulting jointly with PHNs with other stakeholders, and that includes RACGP, the Health Issues Centre, ASIM, larger GP practices, AMA, ANMF, VHA and RACS as well. There are others that haven't been included on there, but the list is exhausting. Overall, we would say that the feedback from our external stakeholders has been positive and encouraging of making change and ensuring that there is equitable access for patients that need a specialist clinic an appointment. I've just one more slide which relates to monitoring implementation, and the department will be monitoring impact at a system level, which involves looking at changes to waiting times for patients by specialty and also overall patient experience via the annual survey of the Victorian Healthcare Experience Survey. Health services should plan to monitor the impact of the referral criteria, as data collection will support analysis that can be used as a basis for planning and improvement, and including identifying any gaps and developing an action plan. And, two examples here that I know that some health services are already looking at, and that's a decrease in the number of referrals returned for further information to our GPs and referring clinicians, and also these are interlinked, but improving the quality of GP referrals being sent into specialist clinics. So that's the end of my presentation, and I will now hand over to Karen to do the next couple of slides. Thank you.
So for those of you who don't know how we've developed the referral criteria, we thought we'd give you a very quick overview of the clinical panels. So for each specialty, a panel is convened. We have an independent chair. We have GP representatives, including the Health Pathways clinical writer and GPLO, relevant nursing or allied health professionals, if that's what's needed, and the heads of unit from every health service that offers the specialty. So we have 2 face-to-face meetings, and we have a lot of follow-up discussion via email. The department pulls together all the published background information that we can find. So that's referral criteria that are already published on hospital websites and those in Health Pathways. We also look at referral criteria that are published in other jurisdictions, and we also have a look at information that we've got on demand for current services. So the panel members identify which are the most important presenting problems that need referral criteria at the first meeting. So we're not trying to cover every single presenting problem that might come in for that specialty. We're trying to cover the most important ones or the highest volume ones. We work through a series of standard questions for each of the presenting problems, and then we draft the criteria. And we then have a couple of feedback loops that we seek feedback on the criteria that's drafted from all of the panel members. We seek feedback from every head of unit in the state if they can't get to the meeting. And we also get feedback from all of the PHN clinical writers across the state. At the second meeting, we reconvene, go through everything that was discussed at the first meeting. Then we draft further referral criteria, and then we start that whole process again. So it's a standard methodology for each clinical specialty. Once they're finalised, the criteria are then incorporated into the relevant health pathways, and they're placed on the department's website. So for those of you who may not have seen it, the web link is src.health.vic.gov.au. And the version on the website is the source of truth. We do ask that you always go back to the live website in case there has been some change. But, obviously things won't change on a day-to-day basis, but you should always go back to the website as the source of truth. The format's consistent for each of the referral criteria, and I'll just make a note that it's important to read every single statement on the page. Don't assume that one section tells you the whole story. So there's a section with information about when an immediate or urgent action needs to be taken by the referring clinician. The next section is the key criteria for referral. Then we go into what information must be on the referral for the referral to be accepted. Then there's information that's additional information the referring clinician might choose to put into the referral. That may help with triaging the referral. The criteria and the information that must be included are focused on assessing the referral, but the additional information might help with triage. There's then a section for additional comments which help the referring clinician, but they also may help how referrals are allocated within the health service. So there might be a comment about patients with a specific need should go to a particular service rather than to the clinic that the referral criteria are for. And finally, there's statements on when referral to a public hospital specialist clinic is not appropriate. There's only a few of them, but they're there. So the statewide referral criteria for the specialties will be listed on the website as they are developed. As Sue noted, 3 go live on the 1st of November. Gastroenterology and obstetrics will be available on the website later this year, and there are scheduled starts for early 2020. And there's 6 more groups of criteria that we're hoping will be on the website in early 2020. The ones that we've had panels already convened for and they've started work on, just to give you an idea, is endocrinology, ophthalmology, rheumatology and cardiology. So they'll be on the website early in the new year. We welcome feedback and suggested improvements about the content of the referral, again by the Specialist Policy Inquiries email address. But I'll just note that there will be future review processes. So send them in, any suggestions or concerns that you have, and they'll all be collated and they'll be available when a review is going to take place. So I'm going to hand over to Roxanne now.
Thank you. So I just thought I'd briefly touch upon what the scope of the PHN's effort is to begin with. So as we've discussed previously at the information session, the PHNs have been funded to partake in the panels, and so that's been a really great process in making sure, as the objectives have said, that we gain a good consensus to support the implementation. The second thing has been that the PHNs have been funded to develop clinical and referral pathways using primarily the Health Pathways platform, but for those regions that don't have health pathways, they will have those same resources available through their PHN websites. And so the idea with that is so that the information within the criteria is reflected on a sort of workforce capacity tool for GPs. And so I'll touch upon the value of health pathways in the next slide. The third effort or piece that PHNs are funded for is the promotion of the statewide referral criteria to the primary care, and obviously partaking in part of the statewide engagement strategy with DHHS, but more importantly, we'll be doing promotional campaigns directly towards GPs on what to expect with the new criteria. So, just to get an idea of why pathways are being developed to support the criteria, if we think about it from a proactive point of view, if we're promoting that these resources are available or people are already users of health pathways, the idea would be that they would go to the clinical pathway of which the criteria is embedded, and if they're following that information, they'll be prompted to comply to the criteria and then send a good referral in. So hence the tick into hospital. However, we do recognise that some people aren't already using the platform, and so we might find that they send or haven't checked the criteria, and they send a referral in that's not suitable or is missing important information. Where we think Health Pathways could help would be that health services redirect GPs back to Health Pathways so that they can, one, look at whether they can do more for that patient within the primary care sector, or whether or not how they order the correct investigations to support an appropriate referral back. So Health Pathways can work in both ways, and I think it's important, as we know, to close the loop and make sure the GPs are supported in this change process as well. So just this is a slide to show you where we would be embedding the actual criteria within Health Pathways for GPs. So that's a typical referral page, and if we have a look, it says criteria and prioritisation. So if we then go to the next slide, you'll see that a drop down will happen and it'll list all the specific presenting conditions with criteria, of which when you click on one, that one there is dystonia, you'll see the page. So the way we've embedded it in our clinical pathways, you can see this is the dystonia pathway. If we go to the next slide, we've pulled out the management section, and if we compare it to the criteria, we can see there that it talks about needing to have persistent symptoms for 4 weeks, and you can see within our management section that aligns. So the pathways are helping GPs to comply and adopt the criteria appropriately. So I guess the exciting bit that we've been talking about for some time with the sector is the media toolkit that's going out to GPs. So this is just a snapshot of some of the resources that we have available. Similarly to the department, we have a fact sheet, but the questions are more designed obviously for the GP. We also have some social media tiles to be used, because we know that's a great way to engage with the general practice. And also you'll see the sort of colourful flowchart image. That's like a postcard or poster that can be printed off and distributed at events or to GPs. In addition, we'll have a media article written which sort of summarises the benefits for GPs for this reform. We'll also have other key messages that can be used to develop other resources relevant for your area. So all the PHNs will receive this toolkit hopefully by the end of this week, and media will start from next week. We'll also be distributing this toolkit to health services, so through GPLO networks, and we're also sharing it with some of the key stakeholders that we engaged with previously who have said that they'd be willing to use a similar content. So if you don't receive a copy, please feel free to get in touch. Either you can go through the Statewide Specialist Clinic email that you've already seen so far, or you can contact me directly. So just this is other ways that PHNs are willing to support the implementation, and I think these are key parts of what PHNs do already for GPs. So it's not necessarily specific to this project, but one of them is that we obviously want to provide practice support to practices that might be finding it difficult to manage, say, return referrals or being able to navigate Health Pathways or the criteria on the website. So if you identify practices who are, trying to use the criteria but are not being successful, please contact your PHN and they will go out and do some targeted practice training. We're also wanting to do any targeted communication to GPs once the reform's been implemented. So if you're noticing that people are not picking up one particular criteria, it seems to be over-missed, we can do a particular campaign to draw attention to that specific criteria. So, and as always, we're open for feedback as well. It's an iterative process, so please get in touch. So, over to you guys.
Thank you.
No worries.
We'll now move on to the questions, the targeted questions that have been sent in to us from the sector. We have, we haven't received a lot, but what we have sought to do is I suppose summarise or theme them, and we're going to go through some of them today. We'll do one at a time. So the first question relates to: can a health service localise or modify the statewide referral criteria? That one's been asked by a few health services. So we just reiterate that the objective of the criteria are that the patient referrals are assessed against the same criteria in all Victorian public hospitals. The criteria have been developed and as a consensus agreed by a multidisciplinary panel, and with membership as noted in that paragraph. Making changes to the criteria at a health service level will result in unequal access to health services, for patients to different health services. So we welcome feedback from the sector on how the criteria could be improved, but I suppose in essence we're saying no, the referral criteria should not be localised or modified by health services. If you think that a change should be made, please advise us, and the department, the PHN and the panel will review the issue raised and determine if in fact a change needs to be made very shortly, or alternatively can be put on the list for a later time. Thank you.
Right, I've got question 2. Are hospitals only using the outlined conditions in the statewide referral criteria? So as I talked about with the panels, the initial focus for the development of the statewide referral criteria has been on conditions seen at most health services that offer the specialty, that conditions that are amenable to primary care management, and their high volume, that the hospitals actually get a lot of referrals for them. So as we've said, that's been developed for ENT, neurology, urology, gynecology, gastroenterology and vascular, and we've got others under development. So if there's no published referral criteria for a specific presenting condition under the specialty, that means that at the moment you just use any local criteria that you have. And if it's for a referral for a specialty that we haven't done any statewide referral criteria, then again you just continue using your local health service criteria. And as Sue has noted, there'll be a staged release of statewide criteria for additional specialties over the coming years.
Now the next question that we received was, what if a specialist wants another condition added to the list that's already there? What we've said is that there will continue to be a staged release of statewide referral criteria for additional specialties and conditions over the next 2 years. The department welcomes input from the sector on additional conditions to be included, and as noted earlier, this should be done via email to the site noted on the slide. Suggestions will be saved for consideration for any further review process.
Okay, what happens if a referral does not meet statewide referral criteria? Obviously the published ones. So health services are required to assess all new referrals against the statewide referral criteria from the go live date. If a referral does not meet the criteria or it doesn't contain the information needed, the referral should be declined and returned to the referring clinician, and they should be advised why the referral has not been accepted. If the health service receives an incomplete referral, but the information on the referral suggests that the patient needs to be seen within 30 days, then the health service should contact the referring clinician by telephone and request the information so that the referral can be assessed immediately. Health services should consider all referrals within the context of a patient's health or social circumstances.
This is probably a question that all health services would want to ask us. Is any ideas on how to encourage specialists to decline a referral that do not meet the minimum data set or the statewide referral criteria? What we would say is that the health service executive for the clinical service is accountable for ensuring referrals are accepted, that they are accepted in line with statewide and local referral criteria. What we would say is that most health services have a head of unit or delegate at most of the clinical panels, and they should be approached to provide support to the project officers as part of this implementation process.
So question 6 was for the PHNs. So when will the PHNs inform general practice of the requirements? So as I mentioned previously, we intend to start promoting to general practice from next week. We've put a lot of time into trying to develop resources that are applicable to GPs and that are also strongly aligned with the same messages within the department to avoid any sort of confusion. So, and we are also very mindful at the moment, there are a lot of reforms going on in general practice, and making sure that, you know, we're rolling things out as they become applicable, and therefore where they're more likely to be taken on board and really implemented by general practice. So we will be supporting promotion to general practitioners as well as any other specific referring clinicians where it becomes appropriate, and will obviously be promoting the use of the pathways to further support our workforce capacity during this change.
So thank you, Roxanne.
No worries.
What is next? So we've got a further webinar planned for the 16th of October at the same time, and the same login details. What we encourage you to do is provide us with feedback and also some further questions that you want answered. In the meantime, we will, if they are sent to us, we will continue to provide answers as they are sent in, but it would be good to share them across all health services via this webinar process. We will also respond and update our frequently asked questions based on the input provided by the sector. So that's the end of this formal presentation. We'd like to thank everyone for joining us, and for those that view the session at a later time. We remain positive about the progress that's being made, and we welcome ongoing input from you about any issues that you might have, both from a health service and a PHN perspective. So thank you very much.